Thank you very much for that nice introduction. I don't know if I'm going to make it clearer. I don't know if I can explain it well enough, and that's why to do these advanced modalities, we really have a whole team. So just like a multidisciplinary tumor board is important for these locally advanced patients, having a good radiation physicist, dosimetry team, everything is incredibly important when we're talking about some of these advanced modalities. So I'll tackle the clinical benefits of IMRT and proton therapy, and then I'll spend just one slide on SBRT for locally advanced, since there isn't as much data on that. And I think my clock is not starting yet either. All right, so same disclosures as before, and for this one, being a radiation oncologist probably is important. All right, so I'll start with IMRT and looking at our bimodality patients that are treated with chemo and radiation. And you just heard in the last talk by Dr. Agrawal that doing chemo and radiation together concurrently has a survival benefit over sequential, or certainly over radiation alone, which was the standard of care. And we also know that local control really makes a difference. So this is a pooled analysis of 1,400 patients from RTOG studies. The number one factor, more so than age, performance status, weight loss, number one factor predicting overall survival was local control. So can some of these advanced modalities help with local control? The earliest study looking at dose escalation, which is an obvious way to potentially help to improve local control, was done in lung cancer in a cooperative group. This was a study that was actually started now in the 1970s, and it showed that as you went from 40 to 50 to 60 gray, you had an improvement in both local control as well as overall survival. The puncher, though, is, as you heard by Dr. Agrawal, we couldn't get higher than 60 gray in the cooperative group setting. So when comparing 74 gray to 60 gray, there was actually a survival decrement. And what you also saw is as you went to higher doses, there are higher rates of high-grade esophagitis, and certainly death from treatment also was higher. There are a number of things that were associated with overall survival. Esophagitis was, and so that's an area, could an advanced modality help with that? Heart dose, believe it or not, was actually the number one factor that predicted for overall survival in the study, and that's something where I think we can see big benefits from IMRT and proton therapy. So in that study, it was a nice even mix of about half of all patients were treated with IMRT and half were treated with 3D conformal. And there's actually a trend toward more IMRT use in the last couple of years that the study was open. But there were two subset, sort of retrospective analyses, or secondary analyses, excuse me, of RTOG 0617. The first was related to quality of life. And here they're looking at a quality of life difference between 60 and 74 gray. As expected, there were bigger quality of life decrements with 74 gray, just the toxicities were high. But if you look at the end, this last bullet points, there was a comparison of IMRT and 3D conformal. IMRT in this study tended to be used for patients with larger tumors and higher stages. And the reason for that, we think, is just patients who had difficult times meeting dose constraints with 3D conformal radiation were more likely to get IMRT, because that technology can help to protect the structures. And just to give a sort of a background on what IMRT exactly is. So with 3D conformal, we basically send radiation in through fixed beams, generally somewhere on the order of 4 or 5 beams of radiation therapy to a target volume. And essentially everything through and through that path is getting the same amount of radiation. With intensity modulated radiation, we can actually essentially curve radiation around normal structures by modulating how much radiation is delivered across the width of a beam. So for instance, if you're treating a tumor in the mediastinum or a lymph node, and the esophagus is right on the other side of that, or the heart is right on the other side of that, you could essentially curve the dose around the heart and esophagus to reduce the dose to those organs. So when they looked at the quality of life comparison, there was a significant reduction in quality of life with 3D conformal radiation, but they didn't see that quality of life reduction with IMRT. And these are just the curves looking at both early time points of 3 months after radiation, 12, and also a late time point of 12 months. 74 gray worse than 60 gray, but 3D conformal was worse than IMRT. And the authors of this thought that the early decline in quality of life that was seen in the 74 gray arm and patients treated with 3D conformal may have actually driven the survival difference that we saw in the 60 versus 74 gray trial. A little bit more of a direct comparison was actually looking at survival between IMRT and 3D conformal. This was the modality of radiation was one of the 3 predefined stratification factors in the study. And like I said, about half of the patients got IMRT and 3D conformal. And again, IMRT patients, much worse tumors, higher stage 3B, larger tumors, and because of that, more lung needed to be irradiated. Despite that, though, the volume of lung receiving 20 gray, which is what we refer to as V20, which we think is the #1 predictor for radiation pneumonitis across all the different patient and radiation characteristics, despite us treating larger tumors with IMRT, there was a significant reduction in the dose to the lung with IMRT, and that led to a significant reduction in the rates of pneumonitis in those patients. IMRT also had the benefit, because the toxicities tended to be less, particularly for esophagitis, patients were more able to complete their full course of chemotherapy. And then lastly, there was no survival difference between the two modalities, despite IMRT having more unfavorable tumors that were treated. Pneumonitis is not trivial, so I'll focus my attention on heart after this. We know that lung can significantly be reduced with IMRT and with proton therapy, but why does pneumonitis matter? It's not always patients get steroids for a few weeks and they're better. This was a review of a like population of 12 studies. All these patients got concurrent chemoradiation, essentially all to 60 to 66 gray, so modern treatment techniques, modern doses. About 30% of all patients developed pneumonitis in the study. 2% of all patients died from pneumonitis. So of healthy chemoradiation patients, 2% of all patients that we see are going to be expected to die from the treatment. So anything we can do to lower those lung doses is important. What other data do we have suggesting IMRT may be better? Well, going back to population-based data, because that's what we do, I guess, as radiation oncologists over the last couple of years. This was a large study of about 2,500 patients with stage 3 lung cancer. They all received chemoradiation, and most of the patients received 3D conformal. There was about a sixth of patients that received IMRT. IMRT tended to have higher doses delivered because they were more safely able to meet dose constraints. And when they compared survival, IMRT did have a significant survival benefit. Those numbers, 17 months versus 14 months, they were the same relative numbers, 17 months and 14 months, that RTOG 9410 showed, showing that concurrent chemoradiation is better than sequential. So something that we take as a standard of care now, concurrent chemoradiation as opposed to sequential, is based on a 3-month survival benefit, and that's the same survival benefit that we see with IMRT. The benefit was even bigger in patients with T3 and T4 tumors. So large tumors, harder to treat, better survival benefit with IMRT. IMRT may be actually more useful in a tri-modality setting as well. So we heard this from Dr. Evans earlier today, that giving radiation with older techniques in the postoperative setting is actually associated with survival decrement. So unlike the Lancet publication that she talked about, this was an update that was done through the Cochrane analysis. And I like this one because it shows the causes of death. So even though postoperative radiation actually reduced the likelihood of dying from lung cancer, it increased the likelihood of dying from other things. And those other things were thought to be deaths from treatment related to cardiac and pulmonary toxicities. So can we do something with modern techniques to improve the outcomes? And we saw both of these. The SEER analyses showed that there is, with modern 3D techniques, a survival benefit. The NCDB was a very clean population. About half of them got IMRT, all got concurrent chemoradiation. And you can see, again, a survival benefit with adjuvant radiation, but these numbers keep creeping up. So the survival percentages, instead of 20 versus 27% with adjuvant radiation, here 34 versus 39%. Now, there are little differences in patient numbers, but a lot of that is half of the patients got IMRT in the second study, and essentially none did in the first study. All right, moving to protons. So I'm going to start off with a complicated physics slide, getting into making everything more clear to you. With protons, the biggest difference is protons stop and photons don't. So as I mentioned, whether it's 3D conformal or IMRT, the dose that enters the patient goes through the chest wall, through the lung, hits the tumor, and then goes out the other side. Now with IMRT, we can be a little cute and modulate how it's going through a patient, but it's going to go through and through the patient. So you can see here, with traditional photons, you send the radiation in. If we're trying to treat a lung tumor that's, say, 20 centimeters or lymph nodes that are 20 centimeters into the patient, you send radiation in. You get to about 100% of your dose just deep to the skin. And as the radiation passes through the patient to get to the tumor, you're actually losing radiation, and losing by means of treating the chest wall, treating the normal lung. When you get to the tumor, you are sort of low on your radiation spectrum, and it continues out the other side. With protons, you're giving less dose at the skin. Now we can actually tell the dose to completely deposit at a certain point, and we call this the Brad peak in proton therapy, where we can actually set where all of the dose of the proton therapy is deposited. And the biggest thing to see is there's absolutely no dose beyond this. So 100% of the dose of the tumor, 0 dose after about a centimeter beyond the tumor. So what that really translates to is less dose before the tumor, similar dose to the tumor, less dose after the tumor. So why could that be useful in locally advanced non-small cell lung cancer? Well, there are a whole lot of reasons. So if we're reducing normal tissue doses, we could potentially reduce toxicity. We certainly can safely treat most every type of tumor. And we've gotten into the situation, even with IMRT, when we looked at the technology that was started to be used in lung cancer, it really lagged behind, for instance, prostate cancer, IMRT, that was started 20 plus years ago. And the first indications for using IMRT in the lung was an apical tumor where you're worried about the brachial plexus dose, or a paraspinal tumor where you're worried about the spinal cord dose. And there's certainly some tumors, even with IMRT, you can't safely treat to respect the spinal cord tolerance. We really don't see that problem with proton therapy. You may be able to more safely escalate the dose. We know that with photons, we couldn't do that well. And then combined modality therapy, that's really a pillar of what we do in this locally advanced population. And particularly if we're talking about tri-modality therapy, protons may more safely be able to do that. And then I'll spend the last 2 minutes of this talk talking about re-irradiation. So just to give you a visual sense, this was a T4 tumor that was invading actually the heart. And IMRT did a very, very good job. It protected the contralateral lung, but you can see essentially the entire heart got some dose. The color is dose in this picture, red being high dose, blue being low dose. The entire heart got some dose. The esophagus is getting some dose, the liver, and essentially the whole ipsilateral lung. With proton therapy, we send the radiation in, we hit the area we need to hit, and we stop it. So we're protecting a lot of the heart, and then essentially no esophagus. So what can we do with proton therapy related to the heart? We talked about heart dose may be important in terms of overall survival, and that was shown in RTOG 0617. This was another indication of that. This was over 500 patients treated with chemoradiation for locally advanced at MD Anderson. And they looked at, as they went from 3D conformal to IMRT to proton therapy, the doses to the heart significantly reduced. The average dose went from 22 gray to 15 gray to 6 gray with proton therapy. What they also saw, and those doses to the heart reduction were a V5, so a small amount of radiation volumetrically to the heart, or higher doses. Consistently, essentially every patient that was treated, the dose reduction to the heart was seen with protons compared with photons. What they also saw, though, is the higher the heart dose, that actually impacted survival in their study. And they controlled for location of disease, extent of disease, and other factors. But the location, the extent of heart dose, which protons can protect the most, actually impacted survival. So that's great. We saw pretty pictures, but what can protons do from a survival standpoint? Well, there's not a whole lot of data. One of the earlier studies, now about 5 years old, is from MD Anderson also. This was a 44-patient study for stage 3 patients. They treated everyone to 74 gray with proton therapy with concurrent chemotherapy. So the same dose, 74 gray, that was too toxic with photons and was killing people with photons, they achieved a median survival of just under 30 months. And this is actually the best survival reported in a bimodality trial, a phase 2 or phase 3 trial. Of course, caveats, single institution, great center, but 30 months is an impressive number. A couple other things to keep in mind with the study: the local failure was only 20%. We would expect that number with chemoradiation to 60 gray to be somewhere on the order of 40 or 50%. So higher doses, there probably is a benefit in local control, and that translated to the survival benefit. The toxicity was actually quite low, so the rate of grade 2 pneumonitis is limited to only 1 patient. So looks like it may be a safe way to deliver high doses of radiation using protons. There have been 4 prospective studies published with sizable numbers of patients, and all of them you can see we're treating into the 70 plus gray range, so doses that we really couldn't safely do with photons. You can see the toxicities are pretty low, so consistently single digits for high-grade pneumonitis and esophagitis as well. Early survival endpoints, but at least encouraging. We certainly need randomized data comparing protons and photons. We currently are lacking that. The only 2 reports comparing protons and photons were both presented at ASCO this past year, just a few months ago, neither published yet. The first one is actually a randomized trial. It was a combination from MD Anderson and Harvard looking at 74 gray with IMRT versus proton therapy. It had a combined endpoint of pneumonitis and or local control. The bottom line of the study is neither was statistically significant. There's no benefit with protons or IMRT as far as local failure goes or as far as pneumonitis goes. The caveats of the study, interestingly, is at the time that this was started, now 6 or 7 years ago, there was a lot of concern of sort of would patients be willing to randomize, would physicians be willing to randomize. So if we have a modality that on paper we think protons is going to be much better for, would a physician want to treat a patient with IMRT, and would a patient agree to be treated with IMRT? So the way they got around that in the study is they basically said any patient that dosimetrically, meaning the dose to the normal tissues, any patient that had an improvement in normal tissue structures with protons would not be eligible for the study. So this study really compared the same doses to the heart, same doses to the esophagus with protons or photons. So the outcome should be the same between the two modalities. There's a National Cancer Database study that was recently reported at ASCO. This was an oral presentation. Big caveat of this is so few patients were treated with protons to date. But what we did see is there is a survival benefit with protons. So unadjusted survival, 15% with photons at 5 years, 22% with protons, and the magnitude and benefit actually went up as you controlled for other factors. So we clearly need well thought out prospective data, and we're going to get two of them. The first, RTOG 1308, this is a randomized trial comparing proton versus photon radiation therapy. IMRT is preferred, but this study does allow 3D conformal for the photon arm. All patients are going to receive concurrent chemoradiation, looking at overall survival. They're also going to look at other important things. So in addition to toxicities, quality of life is going to be an important factor in this, and then cost effectiveness. There's a lot of concern that protons are more expensive than modality than photons. Are they justified in this patient population? And then the other collaborative group study is the Proton collaborative group, and this is a trial similar to what we talked about earlier this morning of SBRT, that if you can treat to higher doses and fewer fractions, it's biologically more effective at killing the tumor. This study is trying to look at that in the locally advanced setting. This question's been asked in the photon world, and unfortunately, the two trials that looked at that both closed early because of toxicity. The thought is with protons, they can avoid that toxicity and improve the outcomes of patients. And the other, just like we heard that not all SBRT is the same, not all proton therapy is the same. So most centers in operation today that have treated lung cancer have used a double scatter, passive scatter approach. It's essentially the 3D version of proton therapy. Something called pencil beam scanning or intensity modulated proton therapy is really the sort of new horizon. Many newer centers are having that technology exclusively. And there really is a difference. So just all proton therapy generally can protect the heart and the esophagus and the lungs better than IMRT can. But even within this, so this is the dose received to the esophagus. This is with the traditional proton therapy. With pencil beam scanning, you can really lower that dose to the esophagus pretty significantly. Same thing with the lungs and the spine as well. So something that I think more to come, and some of the newer studies that are going to be coming out will help to answer those questions more. Very quickly, proton for tri-modality. There's not a lot of data, so I'll just leave you with two hypotheses regarding this. Intergroup 0139, this was a trial looking at neoadjuvant chemoradiation with photons followed by surgery for stage 3A non-small cell lung cancer. What this trial showed was that the local control and progression-free survival were much better in patients treated with tri-modality therapy, but there was no survival benefit because of toxicity increase and unfortunately mortality increase from treatment. So the hypothesis, if we can deliver tri-modality safely, survival will be improved. The second hypothesis I'll say is RTOG 0229. This was published more recently, and this asks the question of can we have better outcomes if you treat to higher doses in the neoadjuvant setting. So all patients got chemoradiation to a high dose, 61 gray, as opposed to a typical neoadjuvant dose is 45 to 50 gray. And what they did after 61 gray, they went to surgery in select centers, relatively small study, but their outcomes were very, very good. So patients that went to surgery, their survival is quite excellent. So again, if we can safely treat to higher doses in the neoadjuvant setting, there may be an improvement in outcome. And protons may be the way to do that. So we don't have data yet in lung cancer, but in a tri-modality setting of neoadjuvant chemoradiation followed by surgery, the question's been asked for esophageal cancer. And looking at photon-based neoadjuvant therapy with 3D conformal, IMRT, and protons, as you quote, went up in sophistication of the technology, the rates of pulmonary toxicity and GI toxicity went down. In the converse, adjuvant proton therapy, there may actually be an even bigger magnitude of benefit. So in the adjuvant setting, there's more risk. The lung is already inflamed. The rates of pneumonitis are higher, controlled for the dose delivered. With IMRT, this is a very sophisticated plan. We're still spilling dose throughout the chest. With proton therapy, we can really spare the great vessels in the contralateral lung. There is some early experience using proton therapy, only 4% pneumonitis and very good 94% local regional control in 28 patients. Ending with re-irradiation, very briefly, rationale for this is we know that some patients are going to fail locally or regionally. Standard of care, because photon re-irradiation has been too toxic, is to give systemic therapy. That systemic therapy has typically been cytotoxic chemo with a progression-free survival in the 4 to 6 month range. Now, of course, we have PD-1 directed therapy, so this paradigm may be changing some, but we still don't think those systemic modalities are curative, whereas re-irradiation could potentially be curative. The problem is toxicity. So every group that's tried to look at re-irradiation in the thorax before has limited essentially to 30 gray, because that's the dose they thought they can get away with safely in the re-irradiation setting. And very consistently, every trial has showed the survival has been 5 months by doing that. The handful of studies that have gone to higher doses have shown better outcomes in the 8 to 14 month range. And the only multi-center trial looking at proton therapy, this was a prospective trial, 57 patients with local regional recurrences from locally advanced non-small cell lung cancer retreated with proton therapy. About 2/3 of them also had chemotherapy with this. And this is a population that was selected for all failing locally. Only 16% of patients had a local, 9% regional failure after this. Median survival from the end of re-irradiation was 16 months. So looks like encouraging results. And certainly the risks, as Dr. Langer pointed out earlier, bigger as you talk about higher volumes that we're treating. And then the last slide is just SBRT. There's no standard role for SBRT in locally advanced. I'd love there to be one because the results in stage 1 are so encouraging. Early reports that looking at this have just been too toxic. So University of Kentucky has the most experience. Georgetown retrospectively and Brown prospectively have only 12 patients. All 3 of them use the concept of they give chemoradiation to the primary tumor and nodes and then give a boost with SBRT to the primary tumor, trying to further improve the local control. Both the Kentucky and Brown, the 2 prospective experiences, have had grade 5 toxicities from that treatment. So I'm interested to see what the Carolina Health System and University of Maryland trial will show. This is a prospective trial looking at SBRT not as a boost, but as a replacement to definitive chemoradiation to the primary tumor. So all patients are getting SBRT to the primary tumor, followed by concurrent chemoradiation to the mediastinum. So in conclusion, we know that local control is directly correlated with overall survival for non-small cell lung cancer. We can't get better local control than we have had with 3D conformal radiation. We need dose escalation to have a survival benefit in that setting, but the toxicities to date have been too high. IMRT may more safely allow for dose escalation. We know that it improves quality of life, reduces heart dose, reduces lung toxicities. There's other data I didn't present about decreasing hospitalization and maybe a better survival modality compared with 3D conformal. We certainly know that IMRT in the adjuvant setting has led to improvements. Looking at the port analyses, survival has continued to go up for a variety of reasons, but I think IMRT is helping to drive that. And then proton therapy really can help further reduce the doses to the normal structures, may more safely allow for re-irradiation, which I think is a great use of the technology, as well as tri-modality therapy. And then we'll see if SBRT does emerge as having a role in the stage 3 patients. Thank you.